so much for having me. I'm really excited to talk with you and all of our listeners about this important topic today.
Absolutely. Thank you. We really appreciate you giving your time to join us today. So let me just start out with an introductory question for you. And that is, what is it that drew you to this particular field of migraine care? Why are you so passionate about this?
Yeah, this is a time in people's lives that is really important where our patients are vulnerable and we're dealing with two patients. We have a mom and a growing fetus, and there's a lot of lack of good data and lack of good information about how to care for this population. And I found that we can no longer continue to tell patients not to breastfeed in order to take their medications or to not offer them treatments because we don't have data. We need the data, and we should share what we know with our patients. And I enjoy going through this process with my patients, talking with them about how we're going to best support them in this really vulnerable period. And I enjoy seeing them go through this really exciting time in their lives where they're welcoming a new person into their family, and that's very exciting. So it's a pleasure and a privilege to get to care for patients in this time of their lives.
Absolutely. That's great. Well, we certainly appreciate having you. We have a lot of questions for you today. Just to let people know that if you have questions, live questions while we're on today, please let us know. I will be inserting those questions as we go through or add them at the end, as long as we have time. But full disclosure, we do have a lot of questions ourselves to get through. So I think we're pretty much covering most of the topics, but I'm sure we've missed something. So if you want to know some information that we haven't covered, then please let us know in the comments and we'll be happy to get back to you. So the first question is, can you explain a little bit about what is going on physiologically during pregnancy and lactation that has such a huge impact on migraine for some people?
Yeah, so there's a lot of changes that happen during pregnancy and lactation in the body. It can be very difficult on the body. There's a lot of blood vessel changes, a lot of vascular changes, cardiac changes. We also see hormonal changes, and there is this steady rise in estrogen that happens over the course of pregnancy, and that actually can be favorable. So there's some great news for those of you that are considering a pregnancy, that for women with migraine without aura, 80% will experience an improvement in their migraine over the course of pregnancy. Usually the first trimester, there's not an improvement, unfortunately, and that is a tough trimester for many reasons. A lot of women experience morning sickness and frequent nausea. But in the second and third trimester, a lot of women with migraine will experience an improvement. And we think this is partly related to the hyperestrogenic state, that you have this steady rise in estrogen instead of having these kind of fluctuations every month, or in perimenopause, the case would be kind of irregular fluctuations of hormones.
Right. No, that makes sense. I know for myself, my migraine attacks got much worse during pregnancy, but I'm not 100% sure if that's just because of the hormones or because I got taken off my migraine medication. So, it could have been either or, but I know that for me, pregnancy was a really rough time.
Absolutely. And there are unfortunately cases like yourself where there is a percentage of patients that will experience worsening during pregnancy. Some won't even have an improvement. They'll just kind of stay the same. And some will go on to have new migraine during pregnancy, in particular migraine with aura, which gets confusing because you can confuse aura with stroke-like symptoms. They can mimic each other. And so if you are experiencing new neurologic symptoms in pregnancy, even if you think this could be migraine, I would get it evaluated.
Right, absolutely.
I'm sorry that you were told to not able to take your migraine medications during pregnancy, because
Right.
I think we need to do better, right? We need to be able to offer treatments to our patients so you're not suffering through pregnancy. That's very difficult. There was an interesting survey that came out a little bit ago that asked about 600 patients, what their pregnancy preferences are. And 20% of them indicated that they would not want to have children or not want to conceive because of their fears about migraine. And so this is something that's really important for us to be addressing and figuring out, not only giving you hope that there is a good likelihood that you will improve, but also a plan in place so that you don't have those fears going into a pregnancy.
Absolutely. And I totally appreciate that. And I should say that after the first couple of months where it was completely out of control, a group of doctors decided unanimously that I had to go back on my medication, and things were fairly smooth after that. And for my subsequent pregnancies, I stayed on it, but I wish I hadn't gone through those 2 months of nightmare. And I totally understand why people are afraid to go through pregnancy with migraine. It's a very frightening thing to think about, especially if you already have severe migraine, to think, oh my goodness, it could actually get worse. That's frightening.
That's a very daunting concept, right? You're not only thinking about how am I going to handle this, but how does this impact baby? Not only the migraine, but the medications or other treatments that you might pursue. And so there's a real opportunity for us as clinicians to partner with our colleagues in obstetrics and with our patients to figure out what's the best plan for you going into this pregnancy so that you don't have those fears and you know what you can do and you know what works for you.
Right, absolutely. That's so important. The knowledge is so important. That kind of brings us to our second question. And this is a very broad question, so you can come at it any way that you want to. But what studies have been conducted on migraine and pregnancy, and what are the findings?
Yeah, so that is a broad question because I could take it different ways. So I'll tell you a little bit about, I talked about how migraine can be influenced by pregnancy, and overall that's favorable, but as we've mentioned, not for everybody. But pregnancy or migraine can have adverse effects on pregnancy. So there are some increased risks for adverse outcomes for mom and for baby, in particular, things like preeclampsia, low birth weight are potential things that may happen for women with migraine. We still have a lot more to understand about this. We don't know the subset of patients with migraine that are actually at higher risk for preeclampsia. What I advise my patients is to be more cautious into pregnancy. Make sure that your obstetrician is aware of your history of migraine and that you're following your blood pressures closely in pregnancy to help you to have the healthiest pregnancy possible. So there is a lot of interest in studying what happens to migraine during pregnancy. But also there are studies looking at the safety of different treatments in pregnancy. I will be honest with you, it's really not sufficient enough to make me very excited about a lot of treatments, but there's growing data about this, there's growing attention to this important field. So we understand that some medications are not safe in pregnancy and we try to avoid those. We understand that some medications may be safe. And so that's a conversation for us to have with patients. And there's increasing attention being given to non-pharmacologic and behavioral strategies that can be really helpful and we know are unlikely to have any adverse effect on mom or baby. And so there is increasing literature, there is increasing information. We have a long way to go. And what I encourage you to do is to have a conversation with your obstetrician in this moment to say, okay, well, what is the available data? And then you can have some shared decision-making with your patient, your obstetrician, with their partner to see what you're all comfortable with in pregnancy.
Right, absolutely. And, I'm actually going to skip to a different question because I think it's relevant. And that is, how do we get our obstetrician and our headache specialist or the doctor who's managing our migraine, who may not necessarily be a headache specialist, how early on should we get them all on the same page and talking to each other so that we are informed about what our choices are?
Absolutely. I think that's really important. So some of it depends. If you are on preventive medication for migraine prevention, whether that's oral medications or some of the newer FDA-approved injectable medications, it's important to engage your headache specialist early on because they may advise you to come off of those medications because those are not safe in pregnancy. And so that could be even months in advance. And that allows your headache specialist to then collaborate with your obstetrician, whether sharing notes back and forth. We're working on developing a program here at Stanford where we're able to collaborate better with our colleagues in obstetrics, in particular, because we are kind of creating more lines of communication between our two groups. It's helpful if they're within the same medical record system that they can more easily. But at least if you are months in advance of conceiving, you can develop a plan and you can workshop it and go back and forth with your different specialists, and your headache specialist can always contact your obstetrician. That's something that I like to do to kind of understand what's the state of my patient's obstetric health and how do we proceed. Many pregnancies are unplanned, and so sometimes we can't have a preconception counseling visit, and that's okay, but we should try to let your headache specialist and obstetrician know at the first moment you're pregnant so they can get you in quickly. That's something when a patient tells me they're pregnant and I've already met them before, I know I need to see them immediately. I know I need to make a plan with them and understand what's happening. And the plan might have to change over the course of pregnancy too. And so communication needs to be fluid throughout the course of pregnancy and postpartum.
Right, absolutely. And I think, we actually had someone in our groups comment a couple of days ago that they're pregnant and they're on a medication, and their doctor told them they didn't know if it was safe or not. And so I think part of the challenge with headache medicine is that, there's so little education in medical school on headache medicine, right? And even with neurological residencies, I was just at AHS and they said, 20% of neurological residencies don't even have a single lecture on headache medicine, which is shocking. And even if everybody did, the reality is most of us don't see headache specialists. So the challenge is that we're seeing doctors to manage migraine who don't necessarily know a lot about migraine. Is our obstetrician in that situation likely to know more about what is safe than the doctor we're seeing who's not trained in headache medicine? Or is it kind of a catch-22? Who takes responsibility for this? It's hard.
That's such a great question. And I'm so sorry about the state of things. I know that it's really tough. We have a paucity of headache specialists, and yet 1 in 5 women has migraines. So we are not meeting the needs of our population. That's a really tough question. And I think it's case by case. It's going to be, working with your obstetrician. I find that our colleagues in obstetrics are amazing and they manage and handle so much. And they may have a really good understanding of what is safe during pregnancy in a way that some other providers might not. And so, I always work closely with my obstetricians because I want to make sure that I am operating under the same information that they are. And so, I often defer to them, but there's a lot we have to learn, and this field is evolving. There's new medications and new treatments in the migraine world that I don't expect our obstetricians will know a lot about.
Right.
And so, coming informed to your appointments and saying, well, this is the newest thing, or this is what I'm on, and educating yourself with these kind of platforms. This is a great opportunity to hear about what medications are definitively not safe, or we don't think are safe, other ways to kind of learn this information. I'll also add that, in pregnancy, I don't know a lot of good websites that talk about the safety of different medications in pregnancy. I had the pleasure of working with some colleagues through the American Headache Society to put together a patient guide that's available on the American Migraine Foundation about different medications in pregnancy that you might think about. From a lactation perspective, there's a website called Mother to Baby, and I believe it's available, and you can plug in the medication that you're taking and see if it's safe during breastfeeding. So there is maybe some more publicly available information with lactation.
Absolutely. That's really helpful. And we'll definitely share that resource from the American Migraine Foundation. They have a lot of great guides on that. And I know that's something that my organization doesn't have. We have a lot of resources, but we don't have a resource on this. So, shame on us that we haven't done that yet. So we definitely need to get onto it. But I'm very grateful for the American Migraine Foundation and that other website. And I think what you said highlights the importance of patients being informed of, basically we need to be empowered with our healthcare. And we talk about that in our group all the time, about the need for us to be empowered. And it may feel like it's not fair, but it is reality. We have to know as much as we can. And especially when we're going into pregnancy and there's, a baby to consider as well, and the impact on that baby, then I think that's really crucial. So we know that migraine attacks can get worse. You explained a little bit about that, or they could stay the same. In some cases, I'm always jealous of those women who say they felt wonderful during pregnancy. I'm like, my goodness, how does that even happen? But it's amazing. Why exactly do we see this wide variety of responses? And are there any statistics for the different responses other than the migraine with aura?
Yeah, I don't think it's delineated much more than that. I wish that we did have more granular data. I'd love to be able to tell you, hey, based on this blood test, you're going to get this much better in pregnancy, so we're going to do these meds. So the statistics that I know of are about 80% of women have an improvement during pregnancy, typically second and third trimester, typically if you have migraine without aura. Some women will go on, about 3 to 6% of women will have new onset migraine. It's typically with aura, which again, as I mentioned earlier, is kind of a confusing entity because aura and stroke can be confused. And some women without aura will report a worsening in the first trimester. And if you're having worsening, sometimes that can portend an even a worse course during pregnancy. And I wish we had a better way of predicting this. We still have a lot more research to do. I'd also love to be able to predict what subset of our patients with migraine will go on to develop preeclampsia. Because we know there's an increased risk, but which subset needs to be on aspirin for prevention of preeclampsia? And we don't know that in the migraine population at this point.
Yeah, that'd be a great day when we know that. And if we're able to figure out ahead of time who's going to respond, excuse me, to what medication. it's like, gold standard of migraine. I think some of these things would be really amazing. So you talk about, new onset of migraine. Is that more likely to happen with people who have a family history of migraine, but someone who hasn't had migraine themselves yet? Or is it completely random?
It can be random. We often think of migraine as a genetically influenced condition, that there's some predisposition to having migraine, and developing migraine around women childbearing years is very common. So it is possible that pregnancy will bring out that predisposition to migraine. You may or may not have a family history that you know of, but it's likely that, there are some family members that may have different versions of the migraine that you experience.
Right. That makes sense. Now, is the same also true with lactation, that you can get through pregnancy, not have migraine, but you start nursing and all of a sudden, wham, you're facing migraine attacks, either worse than what you had before or new when you never had them?
Yeah, so that's another good question. So one thing I should mention is that breastfeeding does not, or migraine does not impact your ability to breastfeed. So migraine doesn't make it so you can't breastfeed. Breastfeeding is a very complex and difficult thing to do, and it's a difficult decision to make. But if anything, what we know about breastfeeding is it can be protective against the recurrence of migraine. It really kind of keeps hormone levels in a more steady state for a period of time. And then we often see that as women start weaning breastfeeding, then the migraine begins to recur. But unfortunately, delivery is a very difficult time, and you can have worsening of migraine after delivery. However, if you're having severe headaches after delivery, it's important that your obstetrician and your headache specialist, or whoever's involved, be thinking about other types of headaches, clots in the brain, or other kinds of problems that can produce headaches. Some women, a percentage of women who get epidurals will go on to have a dural leak and will need blood patching. And the symptoms for that are, if you can't stand up to hold your baby, you need to be lying down. You can't stand up because the headaches are so bad, sorry, then you may need a blood patch. So there are some extra concerns about other headaches that can happen postpartum. And that should be another consideration if you've got new onset headaches postpartum.
Right, absolutely. That makes total sense. And I was going to ask you about, when you're weaning your baby, is that a time? And I was thinking, so I'm glad you got to, to answer that question, even if I asked it, because that's kind of interesting. Do attacks have you may have mentioned this before, and I apologize if you did, but do they have a tendency of being worse in any specific trimester, or does it vary widely?
Yeah, I think, the answer is going to be ultimately that it's individual, but the population studies that we do have show that there is an improvement towards the second and third trimester, which suggests that in the first trimester, headaches are worse. And I see this a lot, that it's not like the minute you get into the second trimester, you're that 80% that's better. It's a gradual thing. It may not be at this, second trimester mark. It may be a few weeks into the second trimester that women who will experience an improvement will go ahead and actually start to feel that difference.
Right, that makes total sense. So again, it's kind of touching on some of the things you said before, but is it possible for people to have new or different migraine symptoms during pregnancy and or lactation? For example, they didn't have aura, now they do, or they get dizziness or sight or speech changes, any symptoms they didn't have before, but now all of a sudden they have that.
Yes, it is possible to have new neurologic phenomena that are associated with migraine that we think of as aura. But it is prudent, if you are having these new symptoms, to let your doctors know, because I can't distinguish over a conversation necessarily whether or not it's aura or it's stroke. And there are some increased risks for stroke and other outcomes during pregnancy because of all of the changes that the body is going through. And so I wouldn't just have the symptoms and wait to talk to your headache specialist, a few days later. I would make sure to get it evaluated. But yes, oftentimes there is the potential to have aura, to have vertigo, to have other phenomena that's associated with migraine that increases in pregnancy.
Okay, we did have a question here that's talking about the risks. So you already covered preeclampsia, but I just want to put people's minds at rest or not. Are there other complications or birth defects that are related to migraine? Is there any justification, in other words, other than facing the pain of going through migraine during pregnancy, that would make women say, I don't want to have a baby?
Migraine is not a contraindication to having a baby. It's important, if you have multiple risk factors for preeclampsia, you're going to want to be followed by probably a high risk obstetrician, and making sure that you're following your blood pressures closely, you're on the right medications. There are some potential other adverse outcomes that come from pregnancy among women with migraine, but we still have a lot more to understand to really know how big is that risk. None of the risks are enough for me to ever tell my patient, don't become pregnant because you have migraine.
Right.
But I want to be realistic about how we're going to manage migraine in pregnancy. I want them to be comfortable with the plan of action that we develop.
Right, that makes total sense. And again, this is another one that you kind of covered, but I just want to make it clear to the person who asked this question: is there a relationship or correlation between menstrual migraine and the severity of migraine during pregnancy, lactation, either positive or negative, or no relation that we know so far?
A lot of women suffer from menstrual migraine, and there are studies to show us that these are more severe headaches, more refractory to treatment, and you are in good company. It is not easy. But what we're seeing with menstrual migraine is or menstrually associated migraine, is that you are having a hormonally triggered component to your migraine. And so during pregnancy, when you have the steady rise in estrogen over the course of portions of the pregnancy, you tend to see an improvement. And also with postmenopausally, women with menstrually associated migraine may see an improvement postmenopausally because you don't have those irregular hormonal fluctuations that you have in perimenopause.
Okay, that's good. We just got a live question in, and I'm not even sure that I totally understand the question, but I'm sure you do. So the question is, should those with intractable chronic daily migraine, that much I understand, be managed by a perinatologist? I'm not sure what a perinatologist is.
So I would go with your obstetrician. They may refer you to maternal fetal medicine or high risk obstetrician. But first, I think you can go with your obstetrician and with your headache specialist to see if you can better manage your headaches. Chronic migraine and frequent headaches is not, in my experience, reason enough necessarily for a high risk obstetrician to be working with.
Okay, and just to clarify to people, I just got a note saying a perinatologist is someone who specializes in high-risk pregnancy. I apologize for not knowing that, but I'm glad that you do, obviously. So it's good to know that migraine does not necessarily mean that you have a high-risk pregnancy, even if you are chronic, intractable, daily, which a lot of people in our communities are. And so it's a very, valid question and valid concerns that come from it. So we're going to move into kind of the nuts and bolts of this talk, which I know a lot of people want to know the answers to, and that's all about treatments. So the first question is threefold. Which prescription medications are the safest to take, both preventive and abortive, when trying to get pregnant, during pregnancy, and while nursing?
All right, this is a hefty question, and this
yes.
is a lot of attention here. So there's some kind of guidelines and tenets that I think are really helpful here. One is that anybody, really, for anybody, and especially as you approach a pregnancy, it's important to really optimize the lifestyle and behavioral and non-pharmacologic strategies. So making sure that you're exercising regularly, you're eating regular meals, you're staying hydrated, and focusing on those treatment strategies that have good evidence for helping with migraine. In particular, cognitive behavioral therapy, biofeedback, mindfulness, these can be really helpful strategies that have better evidence. If you want some mind-body medicine practices, you can consider acupuncture, but you do have to let the acupuncturist know that you are either trying to conceive or pregnant, because there are some sites that can induce labor. So these are kind of the non-pharmacologic behavioral strategies that are really critical, and that should be for everybody, but especially as you're thinking about a pregnancy, this is a great time to hone those strategies. On top of that, we want to think about what do we want to do from a rescue standpoint, and if our patients need preventive agents, we want to think about some guidelines around that. So from a rescue standpoint, one thing that's really daunting is like, oh my gosh, I can't take rescue medications, and how long is it going to take me to get pregnant? What am I going to do? And so one thing that's important is to say, as you're trying to conceive, if your menstrual periods are regular, one strategy that you might be able to use is to say during the first half, between when you have your period and when you ovulate, You can take whatever you need to take for pregnancy, for migraine as a rescue agent. They tend to have a short half-life, so they're cleared out of your system fairly quickly. And then for the second half, between when you ovulate and when you have your period, I would try to be more cautious about what you're taking. So that means that you've now freed up 2 weeks in the month where you can take what you need to take as you're trying to conceive, if it takes many months to do so. And then the other thing to think about is what rescue medications are you using that may be impacting migraine. And so NSAIDs, non-steroidal anti-inflammatory drugs, some of them can actually impact the ability of the embryo to implant in the uterus. It has this funky name called fecundability. So for most NSAIDs, I would try to avoid them pre-conception. Ibuprofen may not be as much of a problem, but I would be cautious about some of the other NSAIDs. And then in pregnancy, it's confusing because NSAIDs are only safe during certain parts of pregnancy. And I find that if you have to track all of that information, it may result in you ending up taking an NSAID at a time where it's not safe or appropriate. And so in general, I try to avoid NSAIDs during pregnancy because only in the second trimester is it really okay to be taking NSAIDs. And then some other rescue medications to think about. So devices, neuromodulatory devices like remote electrical neuromodulation or the Cephally device. These devices are really interesting. They've not been studied extensively in pregnancy. Perhaps some of them a little bit, like remote electrical neuromodulation recently came out with a retrospective study of who used it in pregnancy, and it was overall favorable, and that the device didn't result in any big adverse outcomes from pregnancy. Right. I apologize for the noise in the background.
It's all good.
So hopefully you can still hear me okay. Yeah. So devices can play a really helpful role in impacting pregnancy. So devices can play a really helpful role in helping with migraine, and most headache specialists agree that these are relatively safe options to be using in pregnancy. Some of them are prescription, some of them you can get yourself. And then when it comes to other medications such as triptan, some clinicians tend to be nervous about triptan use in pregnancy. However, the balance of data that we seem to see is that triptans may be safe in pregnancy. I wouldn't advise using them frequently, but sumatriptan in particular has less ability to cross the placenta, so maybe a reasonable option. I would avoid opiates and butalbital containing products, both inside and outside of pregnancy for use as a migraine treatment, because these actually can be unsafe for baby, and they can also increase the risk for addiction or abuse potential. And then just a quick word on two other medications that could be interesting. Acetaminophen is over the counter and it's commonly used in pregnancy. There were some studies that suggested there might be some increased risk to baby with frequent use of acetaminophen in pregnancy, but those were poorly conducted studies. And so most headache specialists and most obstetricians, I believe, feel that the acetaminophen is likely safe in pregnancy, but with some kind of caveats around it, which is that if it's not working for your headaches, don't use it.
Don't take it.
And try not to use it too frequently. That really it should be if you need it. Reglan or metoclopramide is another great migraine treatment that was made for nausea, but it helps with migraine as well. And it's actually been studied decently well in pregnancy. So we do have some data about its safety in pregnancy. And sorry, that was a preview of a number of rescue strategies. Yeah. Happy to take a pause or continue into the preventive agents if that's helpful.
No, let's just take a brief pause. I was just looking up while you were talking because I remember at AHS seeing a paper from one of the devices about pregnancy, and it was the Nerivio that they just did a study. I'm not sure if you've seen that study yet, that they found no statistically significant differences in critical pregnancy outcomes between women with migraine who used the Nerivio device and those who did not. So that's not as definitive maybe as we would really love, but it's a good indication, and it's good to have at least some data heading towards that end, right?
Yes, and full disclosure, I was an author on that study. But what I think is important to highlight is that we have our work to do in terms of studying these devices in pregnancy, studying medications in pregnancy, even if it's retrospective, even if we say in the past, you happen to use this during pregnancy, what happened? That's very helpful information for me to be able to present to future patients in pregnancy. So
Right.
then that one we're very excited about.
Yeah, that's great. And I didn't know that you were an author on it. If I'd looked close, I'm sure I would have seen your name. So I apologize for that. I was so excited when I saw that. But something you said does make me want to just remind the people who are watching this, it's so important to tell your doctors what you're taking. Even if you took it by accident or before you knew you were pregnant, because this will help other people as well, retrospectively. So just to remind you, please don't hide this from your doctor. That information is really crucial. So that's really cool.
Absolutely. I think, whenever I'm seeing my patients, I always get an update about the medications they're on, because it's really important. There can be medication interactions, and there's other considerations that we need to have. I wanted to speak to preventive agents, if that's okay, because
absolutely.
I think that one's a little bit trickier, because preventive agents, it's not that you're choosing when and when not to take it. It needs to be in your system in a steady state for a period of time. It takes time to take it out of your system for some medications. And also the impact of this on migraine can be profound. And so when we think about preventive agents, it's really important to question with your obstetrician and with your headache specialist, do I need this anymore? I've been on this for many years. My headaches are really well controlled. Do I really need to be on whatever medication for prevention? And pregnancy can force that question sometimes. And the other thing is that there are some medications, topiramate, valproic acid, some of the newly FDA approved medications such as erenumab, fremanezumab, galcanezumab. These all are not considered safe in pregnancy. Some we have more data that shows that they're not safe in pregnancy, such as topiramate and valproic acid. For others, for the CGRP, calcitonin gene-related peptide blocking agents, whether they're the monoclonal antibodies or the small molecule CGRP antagonists, such as rimegepant or ubrogepant, we don't have a lot of data that tells us these aren't safe, but we think that they are not, because we think that they may impact fetal development and or increase the risk for preeclampsia. So we don't have a lot of data to help direct us. And right now, most headache specialists would say those are not good medications to be on during pregnancy. The other complicating factor is that the injectable, the erenumab, galcanezumab, fremanezumab, they take months to clear out of your system. We're talking 5 or 6 months to fully clear from your system. And so it's really important to engage your headache specialist in conversations months in advance to make sure that you develop a plan for preventing your headaches. And there are some workarounds here. So you could, for instance, go off of the monthly injectable and maybe go on a Gepant, like atogepant, which can be taken daily and has a short half-life. So you could stop that a few days in advance of pregnancy rather than months in advance. Onabotulinum toxin A, or Botox, is a controversial one in pregnancy. Some headache specialists are very anti, some headache specialists are open to it. I usually share the data that we have available, which is overall reassuring. We do have some data that helps us to think that this is likely safe in pregnancy, but it's a very personal decision, and our obstetricians need to be involved in that. If you wanted to stop it preconception, you'd have to stop it months in advance as well. So there's some planning that needs to happen. Other strategies that are worth bringing up to your headache specialist are things like occipital nerve blocks. I typically use lidocaine in pregnancy, and this is a great treatment option acutely for migraine attacks, but also it can be used. And there's a little bit of data to suggest that if you do nerve blocks on a regular basis, it can actually help in a preventive way. And these are also thought to be relatively safe in pregnancy, but they haven't been studied a lot. Okay, that was a huge mouthful, lots of information.
That's okay. It was great. Really appreciate the information. Do the SPG blocks fall under the same thing? They're safe to use during pregnancy as well?
As far as we know, there was a recent study that looked at SPG blocks in pregnancy, but I would say, the number of patients in these trials is like under 20. It's small. And so it's hard to definitively say, but usually the medication that we're using for SPG blocks, for nerve blocks, is going to be the same as you would get for an epidural in preparation for labor if you decide to do that. And so your body would be exposed to that. So there is some data to suggest that those treatments are likely safe in pregnancy.
Okay, that's good to know. And I know there's some data that shows that the SPG blocks can be helpful for prevention as well as for acute treatment for some people. So definitely worthwhile having that conversation with your doctor. Is there a tier system about, it's a lot of information you've given us, although, I mean, broadly, what I'm hearing from you is some medications are absolutely not safe. Some have a very long half-life specifically. all of the injectables, the monoclonal antibodies, it will have a very, very long half-life. So important to get off them if you're trying to get pregnant. But there are still others that have a short half-life that are not safe. But then there's a whole load that presumably fall into the kind of fuzzy gray area. So is there a tier system that obstetricians use or that headache specialists use, where if your migraine get out of control, and you're not doing well on something that's considered safe, that you can move into that? We're not 100% sure, but the benefit outweighs the risk at that point.
Yeah, I think that's a great question. We used to have this really convenient letter category system from the FDA that was like,
Right.
A is fully safe and X, don't ever touch it in pregnancy, but that was phased out. And so any data that you see that refers to this letter category system from the FDA has not been updated since, I think, 2014.
Wow.
We have a new pregnancy labeling safety rule system that is kind of being phased in. But I would say really this is where your obstetrician, your headache specialist need to kind of collaborate and figure out what to do together, and lean on things like neuromodulatory devices if they're safe for the patient from other medical perspectives, or the nerve blocks, some other strategies. And yes, sometimes we do have to dip into less safe but more efficacious treatment options. It's really a personal decision with the patient. And I want to acknowledge that, yes, there are some theoretical risks with having migraine, with treatment options in pregnancy, but there's also, we don't really know the risk of what a migraine does to baby. That untreated and poorly controlled migraine during pregnancy can result in dehydration, electrolyte disturbances. There are impacts to mom and baby that we also need to acknowledge, and not just say, don't treat it, just deal with it. That's not an appropriate option. So
right, that's good to hear you say that, because this migraine is so stigmatized that if you're seeing a doctor who really doesn't understand migraine, that could be their approach. Just kind of deal with it, and that's not necessarily the right option. I would say it's never the right option, to be honest. We have a live question here where someone is specifically asking about blood pressure medications. Are those safe as a preventive?
Yeah, so some are, some aren't. Some are not safe in pregnancy. Propranolol or Inderal is considered one of the safer options in pregnancy, and also has a good efficacy for helping with migraine. Verapamil as well has decent evidence for being safe in pregnancy. Evidence for helping with migraine is okay. So we're always weighing that kind of like, how safe is it? How efficacious is it? Can we find a nice balance between the two? But some are not safe in pregnancy. ACE inhibitors and ARBs are not. So candesartan, lisinopril, those are not as commonly used for treatment of migraine. Sometimes they could be, but they're not considered as safe in pregnancy. And in most, if not, I think all providers would recommend coming off of those kind of medications and managing blood pressure issues a different way.
Right. That makes total sense. So you covered migraine devices as a non-pharmaceutical option. What about supplements? A lot of people take B2, magnesium, CoQ10, Petadolax, or melatonin. Are these safe during pregnancy and during lactation or not?
Yeah, these are fair questions. There's not a ton of data out there. I believe that coenzyme Q10 is sometimes used in the setting of preconception to help with fertility. And so that's one that's kind of interesting to me. Riboflavin, I believe there might have been a small study as well that didn't show any adverse pregnancy outcomes. There's some like feverfew and butterbur that we want to avoid in pregnancy. I believe that they may be able to induce contractions. And then with magnesium, it's a little bit controversial. And the reason for that is that there were some studies that looked at high doses of IV magnesium given at the end of pregnancy. And they saw that babies were born with bone abnormalities. That the calcium and magnesium were competing for binding. And so because of that, us as headache specialists have said, okay, well, what's the risk with oral magnesium? It's not the same as IV magnesium. It's not the same potency of dose. It won't be absorbed in the same way. Is oral magnesium safe? And it seems to be that we're kind of in agreement with trying to keep the dose of magnesium a little bit lower, under 350 milligrams a day instead of the 500 to 600 you might recommend typically. I would say this: if you found magnesium is the thing that works for you for preventing your migraine, then it's worth having a conversation with your headache specialist and obstetrician to continue the dose that you're taking in pregnancy. But if you're not sure if it's working, I don't know that it's worth continuing into pregnancy.
Right. That makes total sense. Very specific. We're kind of running out of time, so we just have a few minutes. If anybody else has any live questions, please let us know. But we have a question here. How should you time taking medications, your migraine medications, with nursing? Is it relevant or really not relevant?
It depends on the medication. And I think some of it is a personal decision. Some of it depends on the medication. And I would say there's different strategies. You can pump and dump milk if you want to discard milk that might have some medication in it. You can also take a medication after the baby has just breastfed and try to time it so that the time to peak action of the medication is at a time when baby wouldn't be lactating. There are also medications that are unlikely to be excreted in breast milk. And frankly, in general, we have more options available to us that have a more favorable safety profile in breastfeeding than they do in pregnancy. Some, by the way, can also influence how your breast milk production. Some can increase it and some can decrease it. And that's a very, very sensitive thing that, it's important that you be informed, is this going to decrease my milk supply? Because that's a big deal. But I would say it's hard for me to answer that broadly. And some of it may be a personal decision of what you're comfortable exposing your infant to. Also, how old the infant is, right? If you have a preemie and you really want to be careful about they're exposed to, versus if you have a 9-month-old that's breastfeeding and doing well and developing well, and you're just taking a medication as needed, you may not need to do as much differently about that.
Absolutely. No, that makes total sense. So we have a question here about balancing risk versus benefit. If someone's going through a bad migraine patch, how do you balance that risk? But I remember my first pregnancy, the number of times I was admitted to hospital, and eventually I'm just like, okay, enough's enough, right? But hopefully people get to that point before they have repeated admissions. So how do you figure out that risk versus benefit?
Yeah, I think that's a really good point. And firstly, if we can, we want to do as much as we can preconception. I like my patients to experiment with medication or with treatments, neuromodulatory devices, preconception, so we arrive at a plan that they're comfortable with. It may be that doesn't work in pregnancy, but it'd be nice to know if outside of pregnancy that does work, then it gives us some hope. And I think if we can come into the pregnancy with a better plan, hopefully we prevent those kind of that from happening, because that's very, very difficult. I think, when you're having to take medications last minute in pregnancy that you didn't fully get to think through because you're in a desperate state, that's not fair to you. And so it's nice if we can figure out options beforehand. Occipital nerve blocks I really like in pregnancy. If my patient is comfortable with it, I think it's a very reasonable option to help get a patient out of a tough cycle. But we also have to question, if you're requiring admission for your headaches, is there something else going on here?
Right.
Making sure that you're getting evaluated for another process that might be happening, and not just being lulled into this, oh, you have a history of migraine, so this is just migraine.
Right,
So.
that makes total sense. And I should also just add that just because someone like myself had a bad experience in my first pregnancy, or your mother did, or your sister did, especially if it was decades ago, things have changed. There were no, neuromodulation devices available when I was a child or when I was having children. Thank goodness there are new medications now. There's more knowledge. There are devices. So don't take what someone else says or what happened to someone else, as that is going to be what happens to you. Having a baby is just an amazing experience. And it's so sad when people with migraine decide that it's not worth the risk because of the fear of what it's going to be like going through pregnancy. So important to talk to your doctor, to have that conversation. We've got 2 more questions left. One of them is about kind of backtracking now, medications that help you ovulate and get pregnant. How do they affect migraine? Off the top of my head, my guess is going to be the same as birth control, right? Some people it makes them worse, some people not, or is it much worse? I
think, there's a lot of research that needs to be done here. There are all kinds of different protocols to help with assisted fertility. And so I think there's a lot that we don't know, but I do expect that some of my patients will run into worsening. And this is becoming an increasingly common topic of conversation of, I'm planning to conceive, I'm going to undergo IUI, I'm going to undergo IVF. What is this going to do to my migraine? And some of it is we develop a plan, because we need to be prepared if headaches worsen. We might do nerve blocks, we might try other things. And it depends on where in that journey they are. If it's at the egg retrieval process or at the transfer process, we'll kind of figure out different strategies. There are groups that are studying this right now, and I'm really eager to see their research on this. So I need to get back to you with an answer at another time.
That sounds wonderful. I really appreciate that. So glad that there are people out there like yourself who are passionate about this and helping women during this time frame. Final question is, what advice or encouragement would you give to women who are trying to get pregnant or just thinking about it, but who know that they have migraine?
I think, my biggest advice is that don't let the migraine hold you back. Get informed, get information about it, partner with, an obstetrician and ideally a headache specialist that you're comfortable with, that you have a good plan in place. Make sure that they're available to you so that as you go through this process, you have somebody you can contact if you're having a difficult time. But I have a lot of hope that, migraine hopefully will improve for many of you, and you won't need most of the treatment strategies that you come up with together, but at least you have a plan in place. And it's a beautiful time in your life, and I'm excited for you, and I hope you find the partnership you need in caring for you medically.
Absolutely. Well, thank you everybody for joining us today. Thank you, Dr. Peretz, for joining us. You're just an amazing source of information. I know I'm going to pick your brains in the future as well. We will make this event is being recorded, so it will be available on YouTube afterwards. Also helping to take some of the content from this and put it up on our website so that everybody has access to that with Dr. Peretz's permission, of course. But we're so excited that you joined us today. If you have any other questions, please let us know. And as always, please partner with your doctor for your migraine care, especially if you're pregnant or you are considering getting pregnant. Please visit our website. We have a lot of resources. That's migrainemeanderings.com. And again, thank you for being with us today. We appreciate it.